another episode of the series OBGYN Pulse Midweek webinar series. And today we have two beautiful topics that people are going to deal with. One is the FGR, the fetal growth restriction, and the other one, which is always a red flag in the womb, that is to identify dangerous infections in pregnancy. So here we start the session. Can we have the introduction slide, please? Thank you. So here our convener is Dr. Vijaya ma'am, who is known for her academic activities here in the South. And now she's also standing as a candidate for chairperson for Foxy Medical Education Committee 2025. All our best wishes to you, ma'am. And she is a convener of the present OBGYN Pulse webinar series. She has also been the convener of the previous Aksharam webinar series. With 3 decades completely in the teaching field, she is the president of OGSI of 2024-25. She's been the former director of the IOG, the Madras Medical College, from 2019 to 2022. Most of them would be her students here in Chennai. And former director of Institute of Social Obstetrics Gynecology, MMC. And she has also been awarded with Best Doctor Awards in COVID pandemic for her work. She's been a member of Foxy and Oxy Medical Education Committee, state level master trainer and national master trainer in many of the OBGYN practices, and also had been playing a key role in the Lakshya certification for IOG, ISG, KGH, and ESI.
Thank you, Madhu.
Ma'am, more to say about you, but she's a very good academician, and we would like you to go ahead and convene this webinar series episode, ma'am. Thank you so much.
Thank you, Madhu. Madhu is always my friend and my student, and she is into fertility, not into obstetrics and gynecology. Yet when I asked her to be with me, she's there from the start of this Pulse webinar series. And she's MBBS, DNP and MRCOG, and she has done in Diploma Gynae Laparoscopy. She is the clinical director and senior fertility physician of Nova IVF Fertility, MRC Nagar, Chennai, and lots of awards for papers and posters and publications in BJOG. Her special interest is in biological care for poor ovarian and sperm reserve patients, and also in oncofertility. Thank you, Madhu, for being with me.
Thank you so much for the introduction, ma'am. We will start off the webinar with the song, The Prayer.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
Thank you so much. We'll start off with lighting the Kuttuvelakku. Thank you so much. So going into the first session for today, we have discussion on fetal growth restriction. Vijaya ma'am, can I request you to actually introduce the chairpersons and the speaker for the day, please?
Yeah, the first chairperson is Dr. Bassab. Everybody knows about him. He has done his MBBS from Vellore and MD from Vellore, FRC London. He is the director, Ankuran Fertility, okay, Madhu's friend only then, Fetal Medicine Center, and has lots of organization role in Yuva Foxy, Endogyne, AACOG 2023, Wisdom 2024, AACOG, RCOG 29 and 24. And
Thank you, Dr. Vijay. Thank
yeah,
you.
she has lots of awards and achievements. Yeah, very friendly and very nice person. Thank you, Dr. Baza, for accepting me immediately when I asked for to be the chairperson. Thank you so much.
Thank you very much.
Dr. Seema Pandey is, I'm not able to see the full slide. Can you just don't make it full slide, Sagiti?
It's in full slide only,
No,
ma'am.
it's half of the things are cut off.
Okay, sorry. Just a second.
Because I'm not able to see properly. Yeah. Seema ma'am is a MD, FIC, OG and fellow in reproductive medicine, and she's the director of Eva Fertility Clinic and IVF Center. She's the president of Asamgar OG Society, and she's the executive board member for the Commonwealth Association for Health and Disability, co-author of A to Z PCOS, and co-editor of ART Fertility Enhancing Surgery, Foxy Focus Preterm Labor, Foxy Handbook of Drugs and Infertility, and reviewer of Jogi and Safag, and she has a key research in PCOS, infertility and mental health, and she has a key interest in reproductive endocrinology and adolescent health and early pregnancy things, and spreading awareness about PCOS and adolescent health among the rural women. Welcome, Dr. Seema. Can I have the next slide, please? Yeah, Dr. Rama, she's the first one to be there. Rama Garg is a dedicated gynecologist and reproductive medicine for the past 30 years and a reproductive medicine professionalist. And she has a lot of skills in IVF, obstetrics and gynec surgery. And she had an MBBS in R&T Medical College, Udaipur, and MS from Ajmer. And she has lots of experience in Holy Family Hospital, Hope IVF. And now she is having Nilakant IVF and Women Care Hospital, and lots of administrative posts from Ajmer OG Society as a General Secretary, VP, and President, and participated as speaker and chairperson various AAC OG conference and state conferences. Welcome, Rama. Alpana just now called me. She had an emergency section. She'll be joining soon. And she's a professor, Santosh Medical College Hospital, and has special awards in academic excellence and Corona Warrior Award, Global Teacher Award, and organized several CMEs and several. She was an organizing secretary in UPCOG 2020, and lots of teaching experience and publishing to her credit. And she has special interest in fetal medicine and iris pregnancy. Rama, please join whenever you find time. Yeah, can I ask Rama madam to introduce Sita? Basab sir, can you introduce Sita ma'am?
Hello.
Let Dr. Rama do it. She's the one who joined. Dr. Rama, it's your turn to introduce Dr. Sita.
ये थोड़ा कट रही है Dr. Sita. She is MBBS DGO from Mumbai, FICOG, FRCOG, RCOG, RCR in Advanced Obstetrics USG, consultant fetal medicine and obstetrics, Apollo Multi-Speciality Hospital, Ankuram IVF and Fetal Medicine Center, Institute of Fetal Medicine, Kolkata. Honorary Joint Secretary, Bengal OBGYN Society 24-25, Chairperson Genetics and Fetal Medicine Committee, FOXI 2025, President Secretary Society
Thank
of
you,
Fetal
madam. That
Medicine,
should be
Kolkata
enough.
Chapter
Thank
2020.
you. Thank you. We'll go on to the side.
Okay.
Thank
Welcome,
you.
ma'am.
I'll just share my screen. Firstly, thank you, Dr. Vijaya, for this opportunity. And indeed, my pleasure to have Dr. Bashab as well as my chairperson, who's the president of my own society, Dr. Rama, and Dr. She has not joined, right? I'll just share my screen. And I think most of you have heard this, but nevertheless, there are a few things which always needs to be reiterated. So is my screen visible? Yeah, no, okay. So today we're going to be talking about fetal growth restriction and how we need to, what are the practical approaches in dealing with patients with fetuses who have fetal growth restriction. So that's me for you. Thank you once again. So when we talk about fetal growth, we know it's a dynamic process. It's not like just one thing that happens at one point. So through the pregnancy, as the embryo develops and as the fetal grows, and it is dependent on a lot of factors, but mainly maternal, some fetal factors which can affect the growth, and mainly the placental factors. So the maternal hemodynamics, what happens is, maternal hemodynamics that happens in pregnancy is that there is an increase as the pregnancy advances. There's an increase in the uterine arterial flow, which is which is obvious by the increase in the diameter of the vessel. And this happens because of the trophoblastic invasion, which remodels the spiral artery, and that's why the resistance in these arteries decreases, and there is an increase in the available for diffusion and transport. So there's a normal physiological mechanism that helps the fetal placenta to have more blood supply, which can supply the fetus. So in early pregnancy, actually, there's a placental perfusion that aids the fetal growth. And in fact, in very, very early pregnancy, there is actually an hypoxic sort of a state which allows the embryo to grow. And then in the later first trimester, the placental perfusion starts aiding the fetal growth. But in later pregnancy, it's the diffusion of gases and nutrients that aids the fetal oxygenation, and that helps in the growth as well. So when we talk about FGR, growth restriction, basically, what are we concerned? It's because of the outcomes that hamper the fetus. So there is an increased risk of perinatal morbidity, mortality, long-term adverse outcomes are there. And if there is associated prematurity, we have complications because of prematurity, more so if it is iatrogenic prematurity. If it's very early growth restriction, we are worried about these babies having neurodevelopmental outcome and delayed milestones. And as I said, increased risks of non-communicable diseases in adulthood, like they have metabolic syndrome, babies who are born small, they have metabolic syndrome, increased risk of hypertension, type 2 diabetes mellitus later in the future. In fact, when there was a study in the RECODE classification in 2013, they said that, some of these unexplained stillbirths, which we say that the cause is not known, 30% of them are actually growth restricted. And only 11 to 20% of pregnancies that end in stillbirth and severely growth restricted fetuses are actually detected, which means that this is especially in terms of late FGR, which I'll talk about, but most of them go unrecognized, and they wouldn't be called unexplained if you actually known that this was actually the cause, and then you can screen for them in the next pregnancy. So similarly, this was another study done in 2013 in BMG, the Dorsey group. They found that pregnancies with FGR at a 7-fold risk of stillbirths. Undetected FGR, of course, increases the risk further, and half of these stillbirths are actually more than 34 weeks, which accounts for these unexplained stillbirths at term. Leonapon also in the same time they did a study, and they found that 70% of babies dying at term are actually not SGA. Majority of preterm stillbirths are SGA, and majority of term stillbirths are not SGA, which means that if you consider that some of these all these babies who are born stillbirth at term, they have to be small to be able to have a stillbirth. It's not actually true, which is what we will see that in late stillbirths, it is not the actual the centiles which we talk about, it is the falling centiles as well. And that is why they said the majority of term stillbirths are not actually small for gestational age. They may be appropriate for gestational age for that particular, but they have actually fallen centiles, which again I will explain later. So as I said, fetal growth is a dynamic process, and by definition, it is a failure of a individual particular fetus to reach its particular genetically predetermined growth potential, which means it varies from fetus to fetus, and you cannot generalize things for all fetuses. This is often used interchangeably with IUGR, but FGR is what we use. And usually the causes that we tell it is because of unfavorable environmental conditions like placental insufficiency, and it differs from SGA as we will come to know about. So when we talk about the growth, we plot the growth on the centiles. And any fetus where the size, where you look at the AC or the estimated fetal weight mainly, if it falls between the 10th and the 90th centile, these are the definitions, it is appropriately grown for gestational age. If it is less than the 10th centile on standard growth charts, it could be normal, it is SGA, but this could be either normal or it could be growth restricted, depending on what other findings that we have. And FGR is estimated fetal weight less than 10 centile with Doppler abnormalities, which we'll come to, or even one reading of estimated fetal weight less than 3rd centile without Doppler abnormalities is enough to call these fetus as growth restricted. The other thing I was talking about is that the fetus may not be actually below the 10th centile, but it has actually fallen quartiles, which means if the fetus was at anatomy scan at 75th centile and you do a growth scan at 32, 34 weeks, it is almost the 15th centile now, and it is dropped by more than 2 quartiles, that is 50 centiles. It is still above the 10th centile for definition, but it is actually growth restricted. And it is this part which we need to concentrate on, and pick them up, because these are the ones which will eventually end up in stillbirth and you will not know what happened to them. And this can happen, as I said, in small for gestational age, or even for so-called, by definition, average for gestational age fetuses. And this is again phenotypically, the growth restriction is again phenotypically divided into less than 32 weeks, which is early FGR, and late, which is more than 32 weeks, right? But it also means there is a definition of a static growth where there is no forward growth velocity in the AC, or estimated fetal weight, 14 days apart. So even if you see that, it is, if the growth chart is falling, if you see that there has been no growth velocity at all, that also would mean that this baby is growth restricted. So what are the key issues in delivering and improving outcome of these babies? It is basically identify which fetuses are at risk, and then decide what is the most appropriate surveillance approach in these fetuses, and then very importantly determine when exactly to deliver them, because it is a delicate balance of avoiding stillbirth and avoiding iatrogenic prematurity. So when you talk about identification of the risk at fetus, it is typically the booking assessment where we look at risk factors. And as I said, history taking is still a very, very important factor, because all women should be assessed whenever they book, even if they book at 20 weeks, if they're born late or come late, or if they're booked early, like, ideally, they should be assessed for risk factors for growth restriction to identify those. So here is the time when a lady who has come with stillbirth, and we say in the third trimester, okay, late term still, or late IUFT, but if you ask in details that what was the weight of the baby, and if she says yes, it was 2.2 or 2.4, this baby was growth restricted for that. And it is important to ask more details about that stillbirth, what happened. And then even when you find the anomaly scan, because every anomaly scan is a growth scan, and every growth scan is an anomaly scan in if you look at it in that way. So findings at the anomaly scan should also be incorporated into the fetal growth assessment. And then you have to, as I said, the fetal growth is dynamic, so the risk assessment also becomes dynamic. So if the anatomy scan shows something abnormal, we need to take into account if any other factors in the first trimester assessment becomes abnormal, that also needs to be taken into account. So what are the history-based risk factors? The advanced age, if she's BMI is both ways, obesity or decreased weight, high altitudes, which we know, in certain areas, severe anemia, which is still very, very common, smoking, if we need to assess that factor, and of course medical disorders which affect the mother will obviously affect the fetus as well. So chronic hypertension, chronic renal disease, APLA syndrome, pre-gestational diabetes, or any autoimmune disorders will affect these. But the most important risk factor is a previous pregnancy affected by FGR or preeclampsia, and that is where the history taking becomes very important. Very clearly, if she says, I had a very early preeclampsia and the baby was growth restricted, we know, because that is very symptoms. But in the late FGR, the mother might be completely normal, and you might not know unless you ask a detailed history or have notes about it. What about then assessing that how do you take it forward? The women who are at risk for preeclampsia or placental dysfunction, when you assess them in the first trimester, they should be taking aspirin 150 milligram, not only to reduce the risk of preeclampsia, but also to reduce their chance of small for gestational age. So this is one recommendation that's come up in our latest RCOG guideline. And then if you look at the uterine artery Dopplers, they would typically look in the first trimester to pick up high-risk cases for preeclampsia. But when you're doing an anatomy scan, you should repeat the uterine artery Dopplers between 18 and 24 weeks. And then if it is still high risk, this lady is at risk of growth restriction as well as for preeclampsia. But if a woman has normal uterine artery Dopplers at the mid-trimester scan. Serial ultrasound scans can commence at 32 weeks. But if it's abnormal, which means that we don't take the PI, individual PI or notching, if the mean PI is above the 95th centile, we should commence the ultrasound anytime at 24 or 26, 28 weeks, depending on the individual history. Which means here to go to say is that, yes, in a high-risk patient, you would have serial scans from 28 week onwards, but in a low-risk scan, you should still have a third trimester scan, preferably at 32 and 36 weeks, and if only one is possible, one at 36 weeks, right? And when you look at clinical examination, yes, we still have our serial measurement of symphysofungal height. We shouldn't forget it. It should be done properly after 24 weeks of pregnancy, but no more frequently than every 2 weeks. You have to, obviously, you need to give some time for the fetus to grow. So there's no point in checking. And at this stage, really, you will not be seeing them so frequently. So whenever you see them, have a regular, habit of looking at the symphysofungal height. But yes, it should be carried out at any time after 24 weeks. And the first measurement should be carried out by 29 weeks so that you don't miss these early FGRs and you don't wait till 30 weeks to start your symphysofungal height. So sometimes this becomes your pickup point as to refer them for ultrasound, especially in low risk women, because in high risk, you're anyway going to screen them at regular serial scans from 28 weeks onwards. There are certain biochemical markers and ultrasound markers which can tell you that this fetus is at risk, especially when you're doing a first trimester screening for trisomies or aneuploidies. So if the PAP-A is 0.4 more or less, that will itself indicate that this fetus, there is a placental dysfunction. So this fetus is at risk of having growth restriction, low PLGF, and even high AFP. Sometimes these quadruple markers come with high AFP and you're looking and it says high risk for neural tube defects. And obviously neural tube defects, you don't need to do any other test. By a detailed anatomy scan at this stage, you should be able to pick up. But more importantly, it is trying to tell you here that there is also a risk for growth restriction. Similarly, as I said, ultrasound markers, you have your uterine artery PI, which you will do it in the first trimester, even in the anatomy scan. But if there is a single umbilical artery, without any other associated anomalies, then isolated single umbilical artery can also be a prediction for growth restriction or any multiple pregnancy, especially in monochorionics. If there's a marginal or velamentous cord insertion, you would know that this fetus is prone for growth restriction. All this is usually predictive for early onset growth restriction, right? So these are the telltale things that you will look for and see. So what is your practice point first? Take a detailed history, look at the reports, look at you just don't look whether it is low risk, high risk, or intermediate risk. Look at the analytes, like what is the PAP-A, if it is 0.4 or less, and what is the AFP values, what is everything you need to look at. And then, if you have an integrated screening, obviously that's different, right? Now, when you're scanning a fetus for checking its growth, when you check the gestational age, it actually tells you how old you are. And only when you repeat the scans, it will tell you how much the baby has grown. So if you take the weight one day today, you only know your weight today. But only if you take it 2 weeks later, you will know whether you're putting on weight or you're static or you're losing. So that is the necessity to have the growth charts, to have the growth assessed every 2 weeks. And that will tell you what is the growth and the growth velocity. And to identify whether you have grown properly or not, you cannot just take the measurement. You have to assess the chart. You have to assess it on charts to actually see whether you're growing or not. So gestational age is actually assessed by, dating. So before you check whether your fetus is growing properly or not, you have to, this is the most important, take home. One of the most important take home messages is that you cannot assess growth unless you have made sure that the pregnancy has been dated properly. So dating is what you assign, the age that is assigned to the fetus, and it can be done by LMP ultrasound if there is a difference, as I would say. But remember that dating is done only once in pregnancy. Once you have dated the pregnancy and once you have decided that the EDD is by LMP, or if there is a discrepancy or by ART, which is usually known, you will not change the EDD, because when you do subsequent scans, you put the measurements, the machines will give you an ultrasound EDD, but please do not try to change the EDD by that, because by the end, the obstetrician is confused, the patient is confused, and we don't know what is happening to the fetus. So in assisted conceptions, of course, we know if it's a fresh or frozen embryos, and it will give you an EDD. But if it's a day 3 BT or day 5, you accordingly, subtract those days. But the total number of days must add to 266. For early gestational, for dating the scan, ideally you would take between 6 to 9 weeks is the crown rump length, and up to 14 weeks CRL is the best estimate for measuring, for dating the pregnancy. You do not date it very early because you do not use the mean sac diameter. Only when the embryo or the crown rump length is visible, you take a proper CRL, preferably from 7 weeks to 14 weeks, and then you date the pregnancy, because beyond that, it is very unreliable to date the pregnancy. You can use the HCNFL between 14 and 24 weeks, but after 24 weeks, you do not date the pregnancy. You just assess the fetal size and then you repeat the scan after 4 weeks to check if it is growing properly or not, because in that case, the dating becomes completely unreliable. If there is a discordance, yes, you have to date it by CRL. So between 7 to 9 weeks, if there's a more than 5 days discordance, you redate it. And between 9 to 14 weeks, if it is more than 7 days, you redate the pregnancy. And once the pregnancy has been dated, again reiterating, please do not change the EDD. So yes, as coming again, that this is a clinical surrogates, you have maternal abdominal palpation or routine third trimester ultrasound scan. So once you've assessed the dating with, once you've assessed the gestational age with accurate dating, you always plot the growth on charts. You use standard charts, that is, Hadlock charts, and charts that include HC, AC, and FL. So whatever chart you use, there are multiple charts. I'm not going into the details, but whatever charts you use, make sure you mention and you use the same charts every time, and then you see the change in the growth velocity that's happening, and then you check whether this fetus with a less than 10 centile, which is the target fetus, and anything less than third centile is the highest. So how old is the gestational age, how well the baby is growing is by subsequent scans, and you can only assess the growth velocity with growth charts. So here, if you have the growth velocity, typically you have the gestational age on the x-axis, the y-axis, the biometric parameters. You have the 5th, 50th, and 95th centile, and you will see from the anatomy scan, if you plot, you will know whether this baby is growing according to the reference, and you have static growth and parallel lines. So what is centile? It's basically a percentage of values found below a specific value. So when you say that a baby is at 25th centile is 260, which means 25% of the babies will have an AC below 260 at 30 weeks. This is just a measurement. So how do you assess the growth velocity? As I said, all of most preferably, ideally, 32 and 36 weeks, and compared with anatomy scans. Evaluate all the fetuses in which are less than 10 centile, which are small for gestational age, and evaluate all fetuses with a drop in growth velocity who have fallen centiles between 10th to 50th centile, which means that they may be average for gestation, appropriate for gestational age, but they have actually still growth restricted. So practice point 2 is check the dates, plot the growth on charts, have a third trimester scan, preferably at 32 and 36 weeks, and then screen for SGA, FGR in the general population is more accurate when the examination is performed at 36 rather than 32 weeks. So which means that even if you have one ultrasound scan to be done, it's better to do it at 36 weeks. So again, the same thing. The other practice point is that you use the biometry. Measurements should not be used to reassign EDD. I'm telling this again and again because even now we see patients who have different EDDs and they are confused. If you have to dish out the early dating scan, reassign at that point, and then make sure the EDD is done, and preferably have 2 to 3 weeks interval between scans to assess the growth velocity. So again, coming to the definition. So when we talk about SGA, basically SGA fetuses are constitutionally healthy small fetuses, which may be false positive, and diagnosis of SGA is highly dependent on the growth chart being used. So here what we do is to differentiate between SGA and FGR, you need additional biophysical parameters, and here is where the Doppler parameters come into use, and they are the most useful to differentiate. So when we talk about growth restriction, as I said, it is phenotypically differentiated into early versus late. Early is where there is severe placental insufficiency, and it is easily diagnosed because it is very obvious there are abnormal Dopplers, but it is difficult to manage because it is prematurity. You just can't deliver and say all is done. But late FGR is a maturational delayed process which leading to placental hypoperfusion. It is difficult to diagnose or rather easily missed, and the Doppler parameter, because the growth is just marginally reduced and the Doppler parameters may be normal. So this is the Delphi consensus which differentiates between early and late FGR, which says that in the absence of congenital anomalies, AC or even one measurement less than third centile or umbilical artery absent in diastolic flow, or if you have less than tensile combined with uterine artery more than the 95th centile or umbilical artery above the 95th centile. Late SGR, FGR is basically any one measurement less than third or at least 2 out of the 3, that is less than 10 centile, crossing centiles, as I said, and umbilical artery above 95th or CPR less than 5th, which we'll come to. So again, the same thing, telling the differences between the two, that in early onset, it is less common than late onset. It is more easily, diagnosable, and it is usually associated with hypertensive disorders of the mother. So it is picked up easily, but here they may not be there. The biophysical, the mother may be completely normal, and the perinatal mortality, though is low, it is fetus is not very less necessarily small. So the practice point 4 is never accept a growth scan report without Dopplers. They should always be combined with Doppler assessment. Yes, biophysical profile can be done, especially in the late trimesters, in the late FGR. Leica volume per se is less important by itself because it's a chronic marker and it will become late only much later. It will become abnormal only much later. So if the Leica is less, but if the Dopplers are normal, don't just deliver the baby just because the Leica is low, because sometimes the Leica might be low. Even, if you plot it on the chart, AFI of 5, if you look at AFI of 5, you might think it's abnormal, but at 36 weeks in AFI of 5, if you plot it on the chart, it is still normal. So assess everything by will have to be assessed on charts and then take the decisions accordingly. So as I said, delivery timing is a delicate balance because you have to balance between the risk of stillbirth and risk of iatrogenic preterm births, and it is important not just to deliver the baby but to have an intact survivability. So what happens in early FGR is there is an elevated umbilical artery PI. So it follows a cascade of Doppler alterations. The Doppler abnormalities may persist for weeks, and the rate of alteration actually determines the rate of fetal deterioration. So why we're worried? Because, every day is important here. In less than 27 weeks, there's a 2% improvement in neonatal survival per day. And here, after 27 weeks, ductus venosus becomes the best predictor of abnormality. So that will be your criteria for delivering the baby. So that is what the Truffle study said, that the timing of delivery is based on ductus venosus Dopplers in conjunction with the safety net criteria, that is CTG, and that will help in predicting the neurodevelopmental outcome in these surviving infants. What happens in late FGR? The placental damage. Basically the problem here is the placental damage here. So anything less than 30%, if it's damaged, it will not, the fetus actually compensates its growth till 31, 32 weeks, and then it starts falling. So that is why the growth is restricted enough to fall below it is not restricted enough to fall below the 10th centile, but it falls from the previous centiles, and that's why it maintains its growth above the 10th centile, which means to say that the placental abnormality is not that bad that the baby's growth will fall so much, but it has significantly fallen from the previous growth. And that is why the abnormalities in the Dopplers are seen late, and sometimes the umbilical artery Dopplers may be normal. And here in these term fetuses, because they are more susceptible to hypoxia, there is a risk of stillbirth and neurodevelopmental delay. Again, Leica, as I said, it is reduced in FGR, but it is a chronic marker, so you should not, use that as to deliver the baby just because on isolated FGR. Isolated Leica abnormalities. Going to Dopplers, uterine artery is what will tell you whether the cause is a placental problem, and that is why it has a predictive and diagnostic marker. It actually does not have a role in predicting the outcome, but yes, if there is an abnormal uterine artery Dopplers with FGR in late trimester, it does tell you that there is the chance that this baby will have a poor perinatal outcome. What about umbilical artery? As I said, umbilical artery actually reflects the amount of placental damage. So it will become abnormal only when the placental damage is more than 30%. So if it is more than 30% damage, it will show as a high PI of the umbilical artery. More than 60%, it will go on to become absent, and more than 70%, it will become reverse. And abnormal umbilical artery Dopplers can actually predict delivery in the next 4 weeks. But what is the point here to be noted is that in late FGR, because the placental damage is maybe less than 30%, it will not remain abnormal. It may remain normal, and that will give you a false sense of security. Again, all of these values are always better plotted on the charts rather than the absolute values. Middle cerebral is the one which supplies the brain, and normally it has a high resistance flow. But when there is growth restriction and there is a brain sparing effect, the fetus automatically diverts its blood to the more important organs like the heart, brain, and adrenals. And that is when, if that happens, then it will start becoming abnormal both in early and late FGR, but it becomes abnormal very late in late FGR. So by itself, it is not a deciding factor for delivery in either of them. And that is why we rely on this something called a cerebroplacental ratio, which is the PI of MCA and versus divided by the PI of umbilical artery. And this will actually reflect the amount of fetal hypoxia and may become abnormal before the MCA. Of course, it has to be used in conjunction with the growth velocity. And when you plot it on charts, anything growing downtrend of less than 5th centile is what is termed as abnormal. Ductus venosus Dopplers is basically it reflects the cardiac status, and so it reflects the acidosis that the baby might have, and this usually happens in early FGR. So in late, it remains normal in late FGR because the cardiac function is not compromised, and as I said earlier, this is the one that is your trigger for delivery in early FGR. Biophysical profile, it is important because we look at breathing movements, we look at CTG, we look at the mother's fetal movements, which is very, very important. And that is why, these things are to be considered to some extent when we're assessing the fetus. So this is your cascade of events which happens in growth restriction. It's early, especially in growth restrictions, where the uterine artery PI becomes high, then the umbilical artery, then it becomes absent, then reverse, and then we have ultimately CTG decelerations, which is a pre-terminal event. Again, the same thing showing the cascade of events in early growth restriction. And of course, this is where you would have the changes where you would need to deliver them, where if there is a maternal indication or if the umbilical artery Dopplers become abnormal, or which I'll come to the stage-based classification, or DV changes in early growth restriction where you would need to deliver them. So when we talk about all these, now let's come to SGA again. Once SGA is diagnosed, as I said, you need to have Dopplers to check them. Because if the uterine artery Dopplers are normal, you would call them as a low-risk SGA. And if uterine Dopplers are abnormal, you would have a high-risk SGA, right? So if it is low-risk SGA, you can just call them after every 2 weeks. But if it is a high-risk SGA, you can need to call them every weekly. And when you deliver these SGA fetuses, you should consider delivery after 38 weeks, and the pregnancy should not exceed 39 weeks. You can induce labor. There's no need to have a cesarean section, but yes, you must have continuous fetal heart rate monitoring. This is the stage-based classification for FGR, where if you have, stage 1, where the estimated fetal weight is less than 3rd centile, or the umbilical artery PI is more than 95th centile, you would call them weekly and you can take them to 37 weeks. But if there is severe placental insufficiency where the umbilical artery is absent or the DVPI is more than 95th centile, you would call them twice a week and you should not take them beyond 34 weeks. If it is stage 3 where there is reversed end diastolic flow or with the VPI more than 95, you need to actually monitor them every 1 to 2 days, and you should ideally not be taking them beyond 30 weeks. But in very, very early growth restriction, where there's reverse diastolic flow in the ductus venosus, that is a stage where you need to discuss with the family, counsel them whether they really want to continue or deliver them as, depending on what neonatal backup we have. So this is one case where we had a lady, she has had an intermediate risk. The PAPE was very low. At 19 weeks, she had a very early growth restriction, which means that if you have early growth restriction in early trimesters, you must also think of any chromosomal problems or infection. So you have to screen them for that and then take it accordingly. So here she was screened, everything was fine. We went on and then she continued to, the Dopplers became absent, but the ductus venosus also remained normal. We could take her till 32 weeks, but ultimately she developed severe PET. So we had to deliver at 33 weeks, which what I'm trying to say here is in early growth restriction, don't be in a hurry to deliver them because these patients have, these fetuses, they have a long latent period and you can actually carry even if it is diagnosed very early and you have ruled out other things, you can carry on this pregnancy up to 32 or 33 weeks, provided the Dopplers remain normal, right? So the trigger for delivery in early FGR is whether the ductus venosus. Now, whether you wait for the 95th centile or ductus venosus reversal is the question. But yes, you must remember that the high DVPI can be because of external factors and it could be a compensating mechanism of the fetus. So ideally, you should be waiting for ductus venosus reversal because that is the definite element of hypoxia with high suspicion of acidosis. So if you have the facility here, in fact, once you reach high DVPI becomes high, you might have to do the Dopplers every day. And if that is not possible, then it is difficult. But if it is possible, you should ideally wait for ductus venosus reversal because that will improve the survival and give better outcomes for the fetus. This was a lady who had a good and at a scan at 20 weeks. Everything was going on fine. But if you see towards the end that the growth was falling off, the CPR was falling off as well. But the umbilical artery Dopplers remained normal. But ultimately, she was delivered because she had low fetal movements and she was delivered. So this is a algorithm for late FGR where you see that if it is more than 32 weeks, it is late FGR. You monitor them every 2 weekly. If the umbilical artery PI is more than 95th or the CPR is less than the 5th centile, you monitor them weekly. You keep an eye on the fetal breathing movements. You alternate them with CTG because CTG picks up these hypoxic episodes. If the umbilical artery is reversed or absent, you deliver them between 32 to 34 weeks. But if the CPR is falling or if there's abnormal CTG, you don't go beyond, you can go up to 37 weeks. But if all that is normal, you can take them safely till 39 to 40 weeks. So in late FGR, the triggers for delivery is that most remain in stage 1, so you can take them, but it's important to look at the Dopplers. So if the estimated fetal weight is less, but if the umbilical artery PI is more than the 95th centile, you would deliver them at 36 to 37 weeks. But if the abnormal CPR is because of low MCA PI and normal umbilical artery PI, you can take them up to 38 to 39 weeks. So in late FGR, if you have an abnormal CPR, you look at what is causing the abnormal CPR. It is a high umbilical artery PI or the low MCA PI. If the umbilical artery PI is high, do not go beyond 38 weeks. But always listen to the mother because anytime she complains of reduced fetal movements, then you might have to reconsider your decision. So this is the SOG practice guidelines which came up, and this is basically saying what I just said, but it is also important to say mention here that this is what it says, that if the umbilical artery PI is more than 95th centile, you shouldn't go beyond 38 weeks, right? So the practice point 5 is that normal for delivery practice point is normal umbilical artery PI with estimated fetal weight between 3rd to 10th centile is 38 to 39 weeks. If it is severe FGR, don't go beyond 37 weeks. If the umbilical artery PI is more than 95th centile, can deliver up at 36 weeks. But if it is absent end diastolic flow, 33 to 34 weeks, and reversed end diastolic flow in umbilical artery, it is 30 to 32 weeks. Of course, here you'll have to give them steroids and give max self up to 32 weeks for neuroprotection. So the key messages for me today is you should have a uniform approach to diagnosis. Antenatal surveillance should be tailored to the severity of condition. You should have identified appropriate delivery thresholds. With early FGR, you look at the degree of abnormal umbilical artery, but it is mainly the abnormal DV Dopplers and maternal clinical condition which determines delivery. In late FGR, MCA Dopplers precede deterioration. So you look at the umbilical artery and the CPR, and as I said, depending on what is when, you determine the delivery threshold at 36 weeks or later. Thank you so much. There's one more thing to add, that there is no role of nitric oxide donors or low molecular weight heparin, and also no role of sildenafil or activity restriction in any FGR for that matter. Thank you for your patient hearing. Thank you.
Thank you, Sita, for a very nice talk on FGR. But then ultimately the Doppler that matters.
Yeah,
So we should
absolutely.
scan center, no? Because sometimes they say the CPR is less than 1, and after 2 days, if we repeat, they say it's normal. So the scan center's credibility is also very, very important.
Very important, yes. But so here in these cases, if there is growth restriction, you might want to add it on with CTG and see if the baby is fine. Just don't go by the CPR, because the middle cerebral artery is very sensitive to if you put extra pressure, or if the baby is breathing, you might get a false reading. So it is important to do it properly and done by a properly trained person. But if there's any doubt, just don't go by CPR. You look at the falling trend, and if there is CTG abnormalities, only take that, because as of now we don't have a threshold as to exactly when the CPR, if it is less than, much less than 1, you need to deliver. You need to see the falling trend. But as I said, if the CPR is less than 1, if it is falling because of an increased umbilical artery PI, that should be more of concern rather than MCA PI. Okay.
And also the mode of delivery, is it section, if it's absent or reverse diastolic?
So again, it depends if it is absent or reversed in 32 or 34 weeks. That time, usually you would end up in a section because the cervix is going to be unfavorable. But if it is 36, 37 weeks, yes, you can have induce them and try for a normal delivery. But all of them will need continuous fetal monitoring during labor.
Dr. Basab, you would like to add anything?
Hi, thank you, Sita. Wonderful talk as usual, and a lot of learnings for everybody, all of us, I'm sure, all the attendees. Just one thing, like as you rightly said, like your heart is in your mouth when the Doppler keeps on failing. Let's say even if it's an absent diastolic flow, you're waiting for a reversal. You'll be waiting every day, or
Yeah, absolutely.
they say twice a week, they say alternate days, but you just keep on doing those Dopplers. You've told us that every day you gain is an advantage. Is it the days that you gain is the advantage, or is the weight that you gain is the advantage? Because the weight generally is very little that you gain at that point of
Yeah.
time. After a week, normally 150 to 200 grams would be a normal baby. This would be around 25, 30. And you think that, is that making a difference, or that my sleepless nights, let's deliver her and let's give the issues to the headache to the neonatologist. So what do you think means? So what in the evidence shows that the days, like you get 1 week more, let's say 30 weeks to 31 weeks, would that make a difference? Or you may get 850 grams to 900 grams, that
That
would make.
also makes a difference, yes, because most of the NICUs are better equipped to monitor, handle babies who are more than 1 kilo. So the minute you take 1 kilo, you're sort of, yeah, they say they are fine. So even every day is important, because yes, if the Doppler abnormalities are fine and if her blood pressure goes up, you might need to deliver. But even if they're growing very slowly, at one point you might see if they reach 1 kilo, then so even weeks are also important. So it all depends on what the current condition of the Dopplers are, and if the Dopplers are fine, you chug along and you buy those weeks there, because by then the baby would have grown to some extent, not as much as it's supposed to grow, but growing some 15 to 20 grams, or even for that matter. As I said, that baby went on to have 1 kilo. It started off with that, but it did grow, though not how much it was supposed to grow, but it did grow. Yes.
Just one just point, Sita. How strong, or how strongly do we swear by our Dopplers? Man, is that means man, can a Doppler show something and you have be wrong? I mean, that's the important thing. Like as an obstetrician, we swear about it because we don't understand fetal
So
medicine.
umbilical, so
So
that
we
is why, as
understand
I
that.
said, so
So
ductus
how much do we swear by Dopplers? Means that's what
So
the
out
thing.
of all the Dopplers, ductus venosus is, yes, difficult sometimes, but the most easiest is umbilical. So I think anybody can, umbilical Dopplers, anybody can do it. So nobody usually goes wrong in that. So if you want to go by that, even if you don't have the facility to do a ductus venosus Dopplers, you go by the ductus umbilical Dopplers. And if it is, wait for it to become reversed. And then of course, if you have the facility to do ductus, that will be better. But if you have reached 32, 34 weeks, if it is absent, then you wouldn't really wait for duct. So the ductus venosus actually comes in between the 26 to 32 weeks window. right? So that is only about a 6 weeks window where you're actually looking at the ductus venosus Dopplers because below 26 weeks, we don't know how many of us will be able to salvage the fetus. So let's see 28 to 32 weeks. 4 weeks is just the ductus venosus, because beyond 32 weeks, we actually go for the umbilical artery abnormalities. So it is that 4 weeks which is critical. So I think if you want, if you need that much, then you have to refer to a center which does these, or then just go by the umbilical artery if you don't have anything else.
Thank you, Sita. It's in from Dr. Rama, Dr. Anupama. Anybody else has questions? I'm done. Thank you.
Thank you.
I
It's a-
want to ask about the role of amino acids and what we are going to give in this.
Well, there is no proven evidence to show that they improve growth. So as of now, it is not recommended. And once the growth restriction has already happened, I don't think that is going to change anything.
But in
Because
CPFGR, a lot of people are giving it.
yeah, but as I said, the role of sildenafil or these nitric oxide donors, they're not yet, there is no evidence based on that. Yes, there are people doing a lot of things which may not be guidance based or evidence based, but as of now, there is no clear cut recommendation or guideline for that.
The role of fluid and
Sorry, madam?
role of fluid and proteins.
No, nothing. No rest, no fluid. That is not going to change anything.
Amnio infusion. Someone has asked whether oligohydramnias, amnio infusion, does it help?
No. Again, because it is here it is the fluid, because the baby is not producing enough urine, and there is not, so there is a pathology there. So you're not going to improve that just by giving fluid. And as I said, Liker is a chronic marker. If there is placental pathology which is affecting the distribution of blood, the supply of blood, and then the baby is not able to absorb the intake of nutrients is affected, which is reflected in the umbilical arteries. This, just by having fluid around you, is not going to make a difference.
Good
There are two
evening.
more questions in the chat, ma'am, which
Me-
ask
Mila,
Dr. Pramila has a hand raised.
Good evening, everyone. Dr. Sita, it was an excellent presentation.
Thank you, madam.
I just wanted to add a few things. For predicting early onset FGR and early preeclampsia, I think uterine artery Doppler at 12 weeks has a very great role. And it must be included in the
definitely.
level 1 scan.
Yeah,
And if you find the mean PI is more than 95th percentile,
absolutely.
we must add low dose aspirin at that
I
very
did say
time.
that. Yeah.
And in many of my primary patients, if it was too high, it was sometimes 3.5 mean PI in primary. And I screened them for APLA, and they came APLA positive in those primary patients. So you have to be watchful for that also.
Absolutely.
Yeah, that's very, very important. The uterine artery Doppler. Even I found that even this PLGF and serum screening were not very useful. The most sensitive marker is the uterine artery Doppler.
Absolutely.
If you are getting it very high in a primary patient, why wait for FGR and this thing to happen, preeclampsia, and then deliver a preterm? I screened them for APLA. They came APLA positive. I started them on low molecular weight heparin, and then they continued very well.
Okay.
So you can avoid this in a primary patient if you screen every patient for this.
Okay.
But Pramila, you would not be doing APLA tests during pregnancy.
No, APLA
do
you
it
can
earlier.
do. The this thing protein C and protein S you can't do. They are not valid during pregnancy.
Not very
because
reliable if you do the APLA in pregnancy.
APLA is quite okay. APLA can be done during pregnancy. Beta 2, LSC, and this they are valid. This protein C and protein S you can't do during pregnancy. They are not authentic during pregnancy because the level falls during pregnancy.
Aparna, you want to add on anything? Aparna?
No, and nothing much, but I would just like to say that APLA has 3 parts, mostly the known ones: LAC, ACL, and anti-beta-2 glycoprotein. So you don't do LAC, but anti-beta-2 glycoprotein and ACL you can do in pregnancy, but LAC you don't do.
So few of my patients who had mean PI around 3.5, I did a APLA, they came positive, and then I started them on both low molecular weight and this thing heparin.
Okay. A good take
Thank
home.
you. Thank you.
Any chat? Anything, Madhu?
Hello, Aparna and Anupma. How are you?
Hi, Aparna.
Hello, ma'am.
Hello, Dr. Basab.
I think let Aparna talk. I'll answer the questions in the chat box.
Yeah, yes. Thank you, Sita. Thanks. Yeah, very good
Hello,
talk.
Dr. Sita.
Hello.
Hi, Dr. Basab.
Hi, Aparna, you're very busy with the ICOG, I understand.
Yeah.
Shall we move on to the next session?
Yeah, ma'am.
Difficult
So,
when to give, what to give, when to test, and none other than Aparna is the person to talk on pregnancy infections. And can I have the chairperson's CV, please? Dr. Anjana, she's a consultant obstetrician gynecologist, Hapur, and she's doing private practice for the last 30 years. Founder secretary of Hapur OG Society, active member of Hapur Menopausal Society, and actively attached to the NGO Inner Wheel Club, Hapur Greater. Next, please. Dr. Renu is done her MBBS from Kanpur, MS from Kanpur, trained for IUI and IVF in Malhotra Test Tube Baby Center, Agra. Formerly, she was at Hindu Rao. Now she's a senior consultant in Mogan Baya Hospital, Firozabad, and she's a Foxy President, Firozabad branch, and IMA Vice President, Firozabad. Welcome, Renu, ma'am. And she is there from the beginning. Anu, President Uttarakhand OBG Society, and she's a graduate of Lucknow and Masters from New Delhi. And she has done a fellowship from NUH Singapore. And she's a senior consultant in Fujala Hospital, Rudrapur, and first IVF baby to her region. And she's the appropriate authority for the state ART and surrogacy board. And she's got the best gynecologist award and contributed a lot of chapters in the book and Preserve the Uterus, Foxy Focus, and she was a past president of IMA, and she's a co-founder of NGO at Uttarakhand, BHOR. Welcome, Anu. Dipali is a maternal fetal medicine consultant, and she's done a fetal medicine from Lucknow, and she's a certified fetal medicine foundation UK, and she's a president Moradabad OG Society, and she has contributed various as a faculty in national and regional conferences. And she's doing a lot of invasive prenatal procedures like fetal reduction, amniocentesis, CVS, and fetal autopsy also. Executive member in the Society of Fetal Medicine, UP chapter. Welcome, Dipali. Yeah, can we ask Renu, can you introduce Aparna, please?
okay. So I will take this good opportunity to welcome Dr. Aparna. Welcome, Dr. Aparna, after a very wonderful talk by Dr. Sita. Thank you, Vijaya, for having me around. Aparna Sharma, I think in North, most of us are very well aware. She's professor at AIIMS Delhi and a wonderful speaker. She's a fetal medicine expert with expertise in fetal interventions. She's been the secretary of Society of Fetal Medicine last 2 years, and she's the chairperson of multiple pregnancy committees, Stillbirth Society of India, as well as chairperson of AOGD Quality Committee. She's had received the Kamini Rao Orator, and we welcome you and are eager to hear from you, Dr. Aparna.
Okay. Can I share? Yeah.
So everybody around was Dr. D earlier. Aparna has still not changed. She's still the Dr. D.
Yeah. So a very good evening to all of you. Thank you, Dr. Vijaya, for having me here. Thank you, Dr. Anupma, for the kind introduction. And Dr. Sita, nice talk. Really loved hearing it. So I was Dr. D, but I was around. So in fact, I got a message from the organizers that I have not joined, but I was there. So yeah, I think so. I would like to talk about fetal infections, and I think this is something which is very, very confusing, very commonly seen. So when we talk about fetal infections, they could be predominantly fetal, they could be predominantly maternal, and they could be both fetal and maternal. But here, in the next 20 minutes or so, I would talk about mostly those which are predominantly fetal infections, right? Which are also called the torch infections. This is a very good document to read about these infections, to get a clarity on how you should approach to these, in our day-to-day practice. So how do these affect? Is there an indication for torch testing? How do you work up the mother? How do you work up the fetus? How do you manage the pregnancy with infection, and are there any prevention or treatment of fetal infection? So we know that what are the possible effects of torch infection? This could be spontaneous abortion, preterm birth, FGR, structural anomalies, stillbirth, or low birth weight. So this is like an entire spectrum of manifestations of torch infection. But we just had a great talk by Dr. Sita on fetal growth restriction. But the question is that should we be screening for torch infection in all cases with FGR? And that is something that we need to think about. And it has been seen that if you look at torch infection for isolated FGR and especially late FGR, so the incidence is very, very less. So in case of early FGR, there is merit in screening for torch infection. And if we are screening for torch infection, the CMV infection is the most common infection which is associated with FGR. So what is the indication for doing a routine torch screening in pregnancy? Should we be doing a torch screening in pregnancy? So the indications would be if the mother has been symptomatic with a symptom of torch like fever, rash, lymph nodes. If there are ultrasound markers of congenital torch, which we would be discussing. If there is early onset fetal growth restriction, or in some targeted groups, the screening is indicated. And I think all of us agree that there have been reports of patients coming to us with an ambiguous torch report, and we don't know what to do. So essentially, it is not a very good idea to screen everybody with torch unless there are certain indications when you would order a torch testing. And again, before we go on, it's important also to say where we should not be doing torch testing. So we should not do a routine screening for all pregnant women as a part of workup for recurrent miscarriages, and also isolated fetal growth restriction, especially late onset fetal growth restriction. It is not a good test to do a torch test. Recurrent miscarriages, because if a mother had torch infection in the first pregnancy, this will not be a cause of recurrent miscarriages because the woman would be immune to torch infection. So it should not be advised as a panel for recurrent miscarriage. And this is something which is important. So let's start with some cases. So this lady was a previous one abortion, 13 weeks gestation, and she had history of malaise and fever in the first trimester itself, and she's IgM and IgG positive for rubella. And such a patient incidentally came today in the OPD. And what should I do about it? So she's IgM and IgG positive. So will I go ahead and terminate this pregnancy? Will I order some extra tests? How do you interpret this? So yes, torch serology interpreting is actually quite simple if we understand the basics. So, but in case of rubella, we are a little more apprehensive. So in that situation, what are the manifestations of fetal infection? So in case of a rubella, we know that early infection can cause miscarriage. The fetus can be born with a congenital rubella syndrome, or there can be stillbirth at a later gestation. More importantly, we are all worried about the congenital rubella syndrome, which has a severe manifestations, including cardiac defects. There could be eye defects, and there could be CNS malformations, including mental retardation. So this is a serious infection. If it is actually occurring in the first trimester, we need to terminate the pregnancy. But the catch is, how do we know that this is an infection which has actively occurred in the first trimester? So that's what we need to understand. So what is the chance of a fetal infection? So if the fetal infection, if the mother is having an acute infection at less than 11 weeks, then the chance of fetal infection is 90% with a defect of 85%. So if we can prove that the mother has an acute infection in the first trimester of pregnancy, we have grounds enough to terminate that pregnancy. However, as the pregnancy goes on, the chances of fetal defect actually after say 20 weeks or so is literally negative. So as the pregnancy increases, and because the period of embryogenesis is over, the period of teratogenesis is over, after 20 weeks, even if there's an infection, it's not going to cause a fetal defect. So it's important to confirm whether that infection in the first trimester is acute or it is chronic. So again, saying that if the infection is less than 12 weeks, the risk to the fetus is more than 90%. And if the infection is at more than 20 weeks, the risk is very small. So then we come to the next question is, how do we know that she has an acute infection? How would you interpret it and how would you proceed? So we also know in that situation, and this is actually uniform for all torch infections and all serologies, that IgM appears within 3 days, will disappear in 4 to 12 weeks, right? So will disappear within 3 months. IgG will persist throughout life. It will appear within a week, but once positive, it is positive. So as a part of our preconceptional routine, we must advise a rubella IgG. If rubella IgG is positive in the preconceptional period, we are safe to say that, okay, she is rubella immune. Now, if she's IgG positive, now this lady came to you in the first trimester with an IgG positive and IgM positive. How do we know that this is an acquired IgG, which is acute? Because IgG can appear within a week, right? Within a week or two. So is it an acute infection or a chronic infection? And this is the time when we have to do an avidity. Avidity is high when the infection has been old, that is, it has happened at more than 3 months earlier, or low when the infection is within previous 3 months. So when do you call it a recent rubella infection? Is when you have a 4-fold rise in rubella IgG titer. Okay, this lady came to you with an IgG titer positive. So you repeat the titer after 2 weeks and you see that there is a rise, or she came with a report of IgG negative first, IgM positive, and there is a seroconversion, or there is an avidity which is low. So if you have an IgM positive and a low IgG, that is again an acute rubella, or you have a PCR in amniotic fluid, which is positive. So for recent infection, you have an IgM positive, an IgG positive, and avidity which is low in the first trimester. You will say that, okay, this is an acute infection, very high chance of acquiring rubella. So this is, and probably would want to consider. So this is what we are talking about. IgM is positive and IgG is negative. Avidity is low, the diagnosis is primary infection. So this will hold true for all of the torch infections that we are talking about. And I will say, if the IgM is positive and IgG is positive, but the avidity is high, in that case, if the avidity is high, then it will indicate a past infection. And that's why we need to have avidity testing. Now, how do you confirm the diagnosis? Now, suppose you're not sure that, okay, because what really happens is that this lady might come to you at say 16 weeks and you're not sure. Even with a high avidity, you're not sure whether this infection happened in the preconception period or in the first trimester of pregnancy. So how you can do it is confirm the infection with an amniocentesis. It should be done at least 6 weeks after the suspected infection or after 18 to 20 weeks. Again, I am emphasizing at this point in time on this point is because this will again hold true for all your infections. Any testing with amniocentesis has to be done at least 6 weeks after infection or after 18 to 20 weeks, because the fetal urination is established after this time, and you can expect that the virus will be detected in the amniotic fluid by this time. So 2 factors: more than 18 weeks, at least 6 weeks after infection, you do an amniocentesis, do a rubella PCR. If it is positive, this is an acute infection. So amniocentesis, if you think that you had an infection and the patient wants amniocentesis and she's come to you a little later and you think that, okay, there might be a serious chance of rubella infection, you will look at amniocentesis. After 18 to 20 weeks, this is not really required, because what we have seen is that the risk of infection is very less. So if you think that the infection has occurred after 18 to 20 weeks, if the infection has occurred after 18 to 20 weeks, we really do not need to do an amniocentesis. So how do you manage rubella? Again, there is not much of a treatment in that sense. For fetal, definitely, if you think that there's an acute maternal infection, you can offer termination of pregnancy. In this particular case, avidity was low, so the couple opted for MTP. And in the morning, I saw a patient who had IgM positive, IgG positive with a high avidity of 86. So she came to me for reassurance because her gynecologist also told that this is nothing. So I reiterated the fact that this is very less chance of you being affected. Now, IgM has a very notorious reputation of being false positive. So we must be careful when we interpret IgM. So if the IgG is positive and avidity is high in the first trimester, that means your infection occurred more than 3 months before. So you are in the safe period and your baby is safe. So this is what is the interpretation of the case. Now, this was about rubella. If we have any questions, we can put it in the chat box and we can discuss at the end of the talk. Now, we come to the other case who was a 33-year-old lady, second gravida para 1 live 1, ICT was negative. She came with fetal ascites, polyhydramnios. However, the middle cerebral artery was normal. So she was investigated. Now, because the middle cerebral artery was normal, we made a diagnosis that there is no anemia. So this is not an immune hydrops. So when the torch was sent, she was toxoplasma IgM and IgG positive at 33 weeks. Now, is the report relevant? What is the prevalence in India? So the seroprevalence is around 45%. So there is a chance that, okay, this woman would have been negative and she got an infection in the pregnancy. Now, what are the features of congenital toxoplasmosis? It is not as common as CMV, but yes, it could be seen. And the main features are in the brain, eyes, leading to developmental delay, epilepsy. There could be hepatosplenomegaly, which is the most common feature of any congenital infection. And most infants would not have any clinical signs, but later on, they may develop sequelae in the form of chorioretinitis and the subsequent consequences. Now, this patient is in her third trimester with a possible fetal affection. So what is the chance of fetal infection change with the timing? So essentially with the toxoplasmosis, as with the other infection, you can see that the chance of infection is less in the first trimester, but if there is a chance of infection, then the fetal affection is very high, because we know that if the baby gets infected in the first trimester, because this is a period of embryogenesis, you can see that the chances that the baby will have some problem is very high, up to 85%. But if the infection is occurring in the third trimester, although the toxoplasma is going into the baby, this will not cause much of a problem in the offspring. So this is what it is with most of the infections in that sense. Now, interpretation of report, it is the same. But the only thing that we need to know about toxoplasmosis is that it is it's a parasite. So it is a difficult organism to report and to actually diagnose. So the labs have to be reference labs. So you cannot just do toxoplasmosis from any lab which is not a standardized lab and then rely on that report. So is there a role of avidity testing in this particular case? And this is what I would again reiterate. So we know that IgG will become detectable after 2 weeks, but this will persist throughout life. And the problem with toxoplasmosis is that the serological tests are not standardized. So if it is a high avidity, you know that the infection occurred more than 3 months. Now, the problem in this case is that she's already 33 weeks. So that means that she's already 7 to 8 months pregnancy. So even if the infection occurred in the first trimester, high avidity does not rule out a first trimester infection. So in the third trimester, avidity does not have much of a role. So in the second and third trimester, avidity does not have a role. Avidity has a role in the first trimester. So overview of toxoplasma serology is not much different from the rubella serology, but added value is that you have to confirm it from a reference lab. Now, scenario 1, IgM is positive, IgG is negative. Now, I think if it was like, we were talking, I would have asked you, but I think everybody can tell me that if it is positive and
Hello? Aparna? Yeah.
I think her signal has been lost.
Okay. Now it's coming.
It's come?
Yeah, yeah. Make it full screen, Aparna. No. Sagiti.
I guess we'll have to wait till she joins again. In the
Okay.
meantime, if there are any questions, maybe Dr. Sita can take it.
I don't know whether Sita is there or not.
Okay, am I audible?
Yeah, yeah.
Okay, sorry. I think it's raining very heavily here, so the electricity went off. So, so the first question is, if the IgM is positive and IgG is negative, then in that case, you will expect that it's a acute infection. So you would like to repeat the IgG after 2 weeks. If it is still positive and IgG is negative, you would have wanted a seroconversion, but this has not happened. So this is a false positive IgM and acute infection is not there, right? But if the IgG has now become positive, then you better confirm it from a reference lab and it is an indicative of an acute infection. In the second case, if both IgM and IgG are positive, then you would like to confirm this from the reference lab and then do an avidity testing to see if it is an acute infection. In the scenario 3, if the IgM is negative and IgG is positive, then in the first and the second trimester, you can think of an avidity and say that it's a pre-pregnancy infection. And in the third trimester, it is difficult to interpret. So I hope it's not too confusing. The concepts remain the same. If it is positive, the IgG is positive, then it is better that we do the avidity. The low avidity in the first trimester and early second trimester will tell us that it's an acute infection. But in the third trimester, avidity is not helpful. If we are suspecting something, we will have to go for an amniocentesis. So again, before amniocentesis, we can also look for an ultrasound. Non-specific signs of fetal infection remain the same. The brain findings, the ascites, hepatosplenomegaly, FGR, and hydrops. If there is a brain finding, the prognosis is not very good. But if it is only a, systemic findings, the outcomes are quite all right. Again, if we are suspecting fetal infection and in the third trimester, avidity is not very helpful, or in the second trimester, avidity is low, then we will confirm our diagnosis by amniocentesis, DNA PCR of toxoplasmosis. Again, two condition, at least 4 to 6 weeks performed after 18 weeks. The sensitivity is less than 90%. So even is there, you might sometimes miss it because of the low levels of DNA. But if the DNA is not there, the prognosis is good. So is there a follow-up of ultrasound? So even if the amniocentesis is negative and you are strongly suspecting that there could be maternal infection, there is role of serious ultrasound to look out for fetal infection to see that everything is okay. Now, suppose, how do you manage so this is one infection in which there is medical management. So basically, if you have started her, so if you're suspecting maternal infection, you will start her on spiramycin and 1 gram spiramycin orally 3 times a day. After 18 weeks gestation, you do amniocentesis. If there is no fetal infection, you can continue spiramycin to reduce the further chances of fetal infection. If, however, the fetus is affected, Then you will continue with pyrimethamine, sulfadiazine, and folinic acid throughout pregnancy and the baby. So this is one treatment that is to be given for toxoplasmosis. So this lady actually received a combination of pyrimethamine and sulfadiazine with spiramycin 1 gram hourly. The baby girl, the fetal infection with, and also the baby girl was born by a cesarean section, and the neonatal treatment was given by pyrimethamine, sulfadoxine, and eye examination was normal. So again, this is about toxoplasmosis, and we can have questions after this. So before we go, so we now go on to CMV in pregnancies. Now, CMV is in the order of appearance, I would say that CMV should have been the first. But again, this is extremely important, more common. This is a DNA virus. It becomes latent after primary infection. It can reactivate and renew. But the reactivated virus will not cause much of a fetal affection, right? So it is the most common congenital viral infection. 90% is asymptomatic, 10% symptomatic. And sensorineural hearing loss is the most common sequelae, most common cause of hearing loss among non-genetic cause of hearing loss. And 50%, up to 50% infants may be symptomatic. Now, in CMV, there are a lot of things which are happening. Up to 2023, there was no recommendation for a universal serological screening. But in 2024, there was a lot of work and evidence which came up in CMV work. And now there is some European Society of Clinical Virology, which suggests that we should screen for CMV serology in first trimester. I am presenting this evidence as evidence and a consensus which is there, but not to be taken up immediately for practice, because there is still, it is a debate, right? Now, why? Why is it a debate? Because suppose if she is seronegative, right, there is no vaccine. So if you do a preconceptional CMV screening and she's seronegative, what will you do? Like rubella, there is no vaccine. So in rubella, if she's seronegative, you can give a vaccine, but not for CMV. And if she's seropositive, then she will still remain at the risk of fetal infection, although small, right? And even if there is fetal infection, it's not like toxoplasmosis that you can treat it. So you cannot possibly treat it. And routine screening can lead to parental anxiety. So there is a little bit of a concern regarding whether we should screen for CMV or not. However, the people who say that we should screen, they say that if you screen for CMV and she is negative, there would be a possibility that you give them valacyclovir and they do well. The fetuses do better when you treat them with valacyclovir. So this is the emerging evidence. So for the present, it is important to understand that the baseline serology may be obtained for women who are at high risk. That is, those who are immunocompromised, persons living with HIV, right? In all of those women, we must try to get the baseline CMV serology done. So how do you diagnose acute infection? So if there is a seroconversion, that is CMV specific paired sera negative to positive within 3 to 4 weeks. If there is no seroconversion, then you do IgG, IgM and IgG avidity, and the same thing. If the IgM and IgG are negative, then there is no infection. Both negative, no infection. IgM positive, IgG negative, early primary infection or false positive IgM. If the IgM and IgG are positive and the IgG avidity is low, then it's a recent infection. So the same concepts all over again, right? If the IgM and IgG are positive and the avidity is high, then it excludes recent infection within 3 months. So the same thing about the serology. So if the infection happens in the first trimester, the possibility that they will have severe symptoms at birth is 20%. But if it is happening in the second and the third trimester, the chances of fetal affections go down. What are the fetal affections? So I will just describe some of the cases that we have seen. So this lady presented at 20 weeks. She was IgG positive, IgM negative. However, she had oligohydramnios, symmetrical IUGR, echogenic bowel, but she had periventricular cerebral calcification. So you can see these calcified dots here. And she also had extracranial calcifications with mild ventriculomegaly. And somewhere the cardiac calcifications, which are very, very, very rare. Now, and adrenal calcifications. So when we did the AFPCR, amniotic fluid PCR, very high DNA viral load. So this was a proven case of CMV, and she opted for termination. In the other case, this lady was a IgM negative, IgG positive, avidity was very high. Ultrasound findings showed ventriculomegaly with periventricular cysts. MRI showed dilatation of occipital horns with callosal agenesis. Again, amniotic fluid PCR was positive. This lady already was so advanced that she chose to deliver at term, but the baby expired after a prolonged NICU stay. This lady, again, she had IgM was positive, IgG was positive, but the avidity was low. So this was a recent infection. Again, this lady had, see, these septations. So this is the lateral ventricle, and then you can see the septations in this. And also there could be poroncephalic cyst. So there is some eaten up appearance in the brain because of the infection. This is the germinolytic cyst. Again, AFPCR was positive. She opted for MTP. So these are the findings that we have seen: intracranial calcifications, there could be ventriculomegaly, lissencephaly, and then corpus callosal dysgenesis, and then intraventricular adhesions. So all of these findings are quite possibly to be seen in CMV infection. Then if you have, so to confirm the diagnosis, again, we have to do a PCR of the amniotic fluid after 16 to 18 weeks and at least 6 to 8 weeks after maternal infection. How do we know that, how the baby is going to be doing? Now, if the ultrasound examination does not have the involvement of CNS or brain, the outcome is usually better. But if you have a severe disease like a brain involvement, then long-term neurological abnormalities are seen, and that's what we need to counsel them and offer MTP if required. Now, the newer evidence that I was talking about is said that if you start valacyclovir in the first trimester, it decreases vertical transmission, neonatal infection, and MTP for severe abnormalities. So the consensus group definition looked at giving oral valacyclovir to prevent fetal infection. And they did amniocentesis at 17 weeks. If she was negative for CMV, valacyclovir was discontinued. If she was positive, then the prophylaxis was unsuccessful and they were not sure what to do. So the entire thing is that if you screen in the first trimester and she is CMV negative, so you can say that, okay, there is a possibility and you can possibly give them on valacyclovir. So this is something which is coming. Now, in the end about CMV, I'll present a very interesting case. This was a known case of Evans syndrome, which is like a secondary APLA on prolonged immunosuppressants. She had PPIROM at 31 weeks. Cesarean was done. In the hospital course, the baby had severe thrombocytopenia. On the ROP checkup, the baby had retinal vasculitis suggestive of CMV. Initial hearing screening failed in both ears. So bloods of the baby, CMV IgG was reactive, IgM was positive, PCR was positive. So this was a case of immunosuppressed that was completely missed because this lady was prone to CMV. So again, when we went back to see CMV, IgG, IgM was positive in the mother. So in the immunocompromised and preterm delivered babies, we need to think of CMV, which can affect them in the early neonatal period also. So basically, before I go on, so I have just 2 rapid fire questions, cases to end. This case the slide was a little misordered. So in this particular case, she was an RH negative, RH positive with fetal anemia. So parvovirus can present as fetal anemia, IgM, IgG positive. You do not have to do amniocentesis. Parvovirus only ultrasound because it's not a teratogen. You follow them up for 12 weeks. And if there is anemia, do IUD. Now for chickenpox, 2 scenarios. Mother herself has chickenpox, but if the chickenpox is after 20 weeks, the risk of infection to the fetus is very minimal. In case you are suspecting fetal affection, you can look for ultrasound features of fetal varicella or amniotic fluid PCR. Treat the mother with acyclovir within 24 hours of rash. If there is an infection exposure of her child during a pregnant mother, if she's varicella immune, that is, she had a history of chickenpox or IgG positive, no further action. But if the IgG is negative, no chickenpox, give acyclovir and varicella immunoglobulin within 10 days of exposure. So I think that is all about it. And if there are any questions, we can discuss.
Hello. Hello.
Yeah, Anupama.
Hi. Yeah. So that
Ma'am,
was overwhelming, Aparna. So many things you've covered beautifully. And this was something new, CMV, the latest thing which has come about oral valacyclovir. That maybe over the years we will evolve and know better whether the screening is to be done or not. As of now, we are just taking that we are not to be screening routinely. It's only the immunocompromised that we should go about. Yeah.
Yeah.
Wonderful.
Actually, about the avidity, it is very, very clear. This avidity, no one usually understands. Now that Aparna's talk, the postgraduates will be really benefited. And Dr. Pramila want to say something. She has,
Yes.
yeah.
Dr. Aparna, good evening.
Hi, Dr. Pramila.
Excellent presentation as always. I just wanted to ask you, in the case which you, this thing toxoplasmosis, she was 33 weeks. If we would have done the avidity, high avidity would not have given us any inference. But if it was a low avidity, that meant that she had got this infection in the last 3 months.
Yes, yes,
So
definitely.
it would have, the low avidity would have helped.
Yes, yes, definitely, definitely. So
Yeah.
the point
And
is that a high avidity does not rule out.
high avidity would not have led us to
Yes.
any inference because she was already 33, but low would have told us that she has got it in
It's
the
a
second
second.
trimester,
Yes,
after
yes.
second trimester. Secondly, once you diagnosed her IgM, IgG positive, you started her on spiramycin immediately, or you first took her for amniocentesis and
So again, yeah, that is what it is. So basically what happens is, suppose you diagnose a patient in the first trimester, right? Or
no,
you
no,
have,
in this case I'm talking. In this
no,
case,
immediately. We start them immediately. Yes.
immediately. Did you start with spiramycin, or did you
Yes.
start with the? You started with spiramycin before
Yes.
the
Yes. So
amniocentesis.
we start
But in
with
the second, but after the first trimester, we can directly start her on pyrimethamine and sulfatazine. Spiramycin is only given in the first trimester because to
No,
avoid
so-
teratogenicity.
No. So the thing is that the effectiveness of spiramycin is for decreasing the transmission from mother to child.
Okay.
If the child is already affected, the role of pyrimethamine and sulfadazine is to decrease the fetal affection. So if there is a
Okay.
fetal infection, fetal manifestations will be decreased. Why do you want to give pyrimethamine and sulfadazine unnecessarily? Because they are more toxic unless
Okay.
there is a proven fetal affection. So if the amniocentesis comes positive, then you will
Then
give
you start.
sulfadazine.
Okay.
Yes.
Okay. Okay. Thank you. And what we can do is, if the patient is coming for preconceptional counseling, and the way we screen for rubella and chickenpox, only IgG we get it done in a preconceptional patient. Why can't we do a CMV IgG also, so that we know if she's already IgG positive? We are really because in a secondary CMV reactivation, the fetal infection is very less. If she's already
Very
CMV
less, yeah.
positive, IgG positive, we are not worried that she will get a CMV or the fetus would be affected. If she is CMV IgG negative in a preconceptional period, we should, whenever she gets a fever or anything, or even then we can screen for IgM IgG. We can
Yes, yes.
screen.
Basically, I have started doing this.
Yeah,
but
I am doing in preconceptional patients who are coming in preconceptional. I am getting the IgG done.
Yeah, so currently I would not recommend this on a public platform because there is much evidence to be generated, much research to be done around it. Yes.
But the IgG in preconceptional period can tell us our immune status.
Yes, yes.
Okay,
This is the
thank
only
you.
place which I can think of having some importance of the routine torch profile, which we keep seeing every day for done for RPL,
In
which is
preconceptional, you don't need to do IgM. You just need to do a IgG in a
IgG.
preconceptional
Yeah,
patient. Only IgG, and then you know
IgG.
the her immune status. Only IgG in preconceptional. That's all. Just to
Yes.
know our immune status.
But the prevalence
Okay.
is high CME prevalence. What is in AIMS, Aparna? prevalence
So,
of
ma'am, it's actually between 80 to 85%. It is
Yeah, CMV majority are positive. CMV.
so basically zero immune. Most of them are zero immune. So
Yeah, majority. Yeah, 90%. Even more than rubella. Rubella, sometimes we get many patients rubella negative and then we have to vaccinate them.
How long do you ask them to wait for pregnancy, Dr. Parna, after giving the vaccine? 1 month or 3 months?
These days it is 4 weeks
1 month.
only.
1 month, yeah. And even if they conceive, that's okay because it has not shown to be teratogenic.
Yeah. And I'm screening also for if there is no history of chickenpox in the family. I'm screening for VZ IgG also in a married, and in an unmarried, then I give the vaccine without screening if she doesn't have any history or she doesn't have any record of chickenpox. Because many patients come VZ IgG also negative.
what about the mode of delivery in chickenpox in the third trimester, Aparna?
Normal
So, madam,
delivery.
it is, basically, if there is herpes, then we say that, you should
Yeah.
avoid it because you can lead to neonatal herpes. But otherwise, active chickenpox, we should try and avoid delivery during that time. But it's not a genital lesion, so you can
Allow for a vaginal delivery.
vaginal. Only herpes has a genital lesion. So there you should avoid delivery if there has been a herpes in the third trimester, but that too within 2 weeks.
Mm-hmm.
So if it is an active chickenpox lesion, wait for 3 to 5 days for the initial.
Yeah.
Yes,
You
yes. It's like any viral illness. You try to avoid delivery during that time, unless she goes into labor and she delivers on her own.
Okay, Aparna, I think we are done with that. And any questions will be intimated to you. Maybe they are all tired, I think, the PGs. Okay. Thank you, Aparna, for such a wonderful and difficult topic to understand.
Very nice webinar.
Very nice, very nice.
Do you
Really,
have
Dr.
the
Vijaya, I
recording
must
available
say
of
that
this?
both of your speakers have been too good. And this topic, especially this fetal infection, right from my PG time, if I remember, was always a bottleneck for us, very difficult to understand and overwhelming.
The
But you
YouTube
covered
also.
beautifully, Aparna.
It will be there in the YouTube also. You can watch Aramse. And thank
Yeah.
you, Aparna. Thank you, Sita's left, I think, for accepting and be on the webinar for me. Thank you so much. Yeah.
Thank you. Thank you very much.
Batu?
Thank you, all the delegates. Thank you, all the faculties who have been there and the two speakers. As everybody is now aware, the two excellent speakers have done a great job. Thank you, madams. Thank you so much for accepting our invite and being here tonight on the webinar. Thank you so much. Thank you so much, everybody. Sahiti and the Shield, thank you so much for providing us this platform. Ma'am, would you like to conclude?
Thank you. Thank you, everyone, for being there. Even at 9 o'clock in the night, I know it's late. And thank you, Aparna. Amidst a busy schedule, I know you will be in the theater or something. I was just thinking. Thank you so much, Aparna.
Thank you.
Bye. Good night, everyone.
Good night.
Good night, ma'am.
Good night, Aparna. It's rained very heavily, na, Gurgaon mein. Okay, good night, everyone.
Thank you,
Good
Pramila.
night. Good night, everyone.
Good night.
Everybody, thank you so much. Yeah, thank you.